I'm LeAnn Maloney. I'm the Quality Director at Caldwell Medical Center in Princeton, Kentucky. We are a critical access hospital located in the western portion of Kentucky, and we decided to tackle opioid medications due to the magnitude of harm associated with adverse events in these medications. At first, we really didn't know that if we had a problem or not. We used triggers looking for the Narcan use within our facility to try to identify events. We did not identify any Narcan use other than what was used within our emergency department, so we looked at rapid responses and in-house codes to try to identify events. We were able to identify 3 events within the past year that were directly related to opioid medications. All 3 of these events were unrecognized and unreported. So we knew immediately our problem was worse than what we thought, just because we didn't know how to identify what our problem was and how to take appropriate action. The first thing we did was administer an opioid knowledge self-assessment test to all of our nurses, physicians, and pharmacists. We were humbled by our findings. There was a lack of knowledge throughout nurses, physicians, and pharmacists on opioid medications. Physicians were not able to recognize the difference between opioid naive and tolerant, how to convert opioid doses, or how to prescribe appropriately. Nurses had a lack of knowledge on how to recognize respiratory depression and oversedation, how to assess and monitor patients. So we did widespread education with both physicians and nurses. Nurses particularly were educated on how to recognize respiratory depression, oversedation, and how to assess and monitor patients. We changed our monitoring and assessment practices to include not only pain assessment and vital signs, but also a sedation assessment and a respiratory assessment in patients receiving opioid medications. We used the POS scale, the Passero Opioid Sedation Scale, to help us assess the patient's level of sedation. And we obtained capnography machines to help us monitor end-tidal CO2 as part of our respiratory assessment in patients receiving opioids via PCA, continuous opioid infusion, and high-risk patients within the first 24 hours post-operatively. We also use capnography on patients receiving epidural infusions. The POS scale has been phenomenal in helping us assess a patient's level of sedation. Where nurses in the past had administered opioid doses are now holding doses based on assessment findings with POS, notifying the physician, administering non-opioid analgesics, and then restarting the opioid dose at half the dose whenever the patient does have an acceptable level of sedation. We are beginning to identify 3 to 4 of these types of near misses each month where nurses are holding doses and physicians are changing doses based on assessment findings. And we are at 0 adverse events with opioid medications at this time. We are now beginning to target our community because we do have a large number of patients who present to our emergency department with accidental opioid overdoses who receive Narcan. So we're targeting our community with education on how to take their opioid pain medications safely and warning signs of when the patient needs to present to their physician or emergency department for treatment. Hopefully, as we increase our community education, we will see the number of events of patients presenting with accidental overdose decrease.